Thank you for inviting me to come here. It's been a very good conference this year. It always is good, but I think this year it's gone further than it has before. I would start saying that I agree with lots of the previous speakers' points as to what we do in terms of treating. So one of the major problems, at least in the Nordic countries, is that we do not have enough doctors that can diagnose and treat ME patients. So many of the doctors would say, well, I know that there's something called ME, but I don't know what to do about it. So that's why I'm going to present, well, this is my disclosures, a primer on treatment in myalgic encephalomyelitis, because we need that out in the general practice, because there are so many patients, and we need more doctors to be interested in this. And in order for them to do it, they have to know what is the background and how do we treat it. So in 2021, there was a care service center established in Norway, where severe patients with ME could come for a month or longer in order to be treated and rehabilitated. And they developed a treatment plan for the clinic. And so in January 2023, I talked to Doc, who was in charge of that treatment plan, and we talked about, couldn't we make this a European treatment plan so that we coordinate what we are doing? And we wanted to make it a little more manageable, and so we made it into a Nordic plan. And we've had some meetings, and what we talked about is that it should be simple. Not that GPs are not clever. They are clever. There are two working at my clinic, and they're pretty clever. But they have so many things that they have to know about. So it would be much easier if they could just click in and read the main points on ME and how to treat it. So the comprehensive version, which is what Dag Stola has been working on, is ready now to discuss in the group. And so the next part is to look at this primer. So the aim is to provide an updated primer on ME/CFS and suggest treatments for general practitioners. It's to provide an easily accessible form that has the potential of being used in clinical practice. We have done that before. I've been involved in something we called Heart Doctor, which was a way for the general practitioners to have easy access to all the information on different heart diseases. So we thought that that would be the way to do it. So what we have in there is we have contents with the main symptoms and causes. So fatigue, how to do the diagnosis, the probable causes, what is mitochondrial dysfunction, what happens when you exercise and you have exercise intolerance, neuroinflammation, neuropathic pain, sleep disorders, autonomic dysfunction. You can click on each of these and get some information on all of those with references as well. So the other part is the treatments. So we're focused on persistent viral activation, mitochondrial dysfunction, neuroinflammation, and autonomic dysfunction. It's probably going to be expanded because this is something that we are going to discuss. So for example, what you can do is you can just simply click up here on fatigue, and that would take you to this page, but you're not supposed to read this. This is too much. It's too busy, so I have reduced it so we can put it in a PowerPoint. So these are sort of the highlights on fatigue with the reference over here. So explaining that fatigue is a very common condition. Chronic fatigue is also a common condition, but there are other things in there that we have to attend to when we are looking at ME/CFS. So if you click on mitochondrial dysfunction, you'll get an overview of that, and stressing that mitochondrial dysfunction is a central part of ME/CFS, and explain what has happened and what actually happens in the mitochondria is very similar to hibernation. The humans are not supposed to hibernate, but the bears, they shut down their glucose metabolism and rely on fatty acids, and we cannot do that, but that's what ME patients are trying. So what the abnormality seems to be is to reduce the carbohydrate oxygenation. What can we do about that? So this is just a short overview of what mitochondrial dysfunction is, with a few references on that. And when we go into treatment, we would, for example, highlight the medical treatment for neuroinflammation. We have different things that we can do there, and one of them would be low-dose naltrexone that apparently most people are using now. It explains a little bit about what naltrexone is, what's the chemistry like, and what's the pharmacokinetics of it. What do we have for studies that have looked into LDN? We don't have, unfortunately, a good randomized clinical control study yet, but there's one going on at the moment. And then it ends up with a suggested dosing scheme, because our clinical experience says that we cannot start on the full dose. That will give too many side effects. So that's why we do this titration, because one of the problems with low-dose naltrexone is that the uptake, the bioavailability, it varies between 5 and 40%. So you have to find the right dose for the right patient. It's not one size fits all, which goes through all of the forms of treatment that we have for ME/CFS. We also look at dietary supplements, because as you mentioned, there are not that many registered medications, so we have to look at dietary supplements. And one of the ways that I started out with was when a patient mentioned something, I would study it. If a patient, for example, says, I can't live without PA, which is what I'm going to show you, then I have to study and see what's the background literature on this, and this is something, is it something I would think would work for my patients? And then I would start patients on that and then accumulate a lot of knowledge on that. I think we have about over 1,000 patients in the clinic, and for this PEA, we have, I think, about 600-700 on it, so that would be a good, if we look back at what had happened to these patients, that would be a good way to look at it. So with PAA, again, explain what is the biology, or the what is the chemistry. It's an endocannabinol, so we actually do produce cannabis in our bodies. We have 2 cannabis receptors, CB1, which is the funny one. No, I mean, that's the one that you like to have action on, and then there's the CB2 receptor, which works on inflammation, and that's where PEA has its effect. And PEA is primarily accumulated in the hypothalamus, so it has an effect on hormones and the autonomic nervous system, and we have, I think, very good results from what we're doing. It has been shown to decrease release of pro-inflammatory cytokines. It stimulates the CB1 receptor, and this receptor is very abundant on microglia cells, and that's probably why it has a good effect on neuroinflammation. We looked into the possible side effects, and in rats, this is the usual daily dose. In rats, you can give them up to 1,000 milligrams per kilogram. So this is far from where the side effects may arise. So this is a safe compound to use. So I know I'm a little ahead of schedule, but that doesn't matter, I hope. And so the summary is that this is work in progress. So what we want to do is to have something that can be used in daily clinical practice. And we know that the contents have to be short and to the point. No more than a single page, and maybe up to 15 references. And that's what we think or what we've heard that the general practitioners would like to have. So the next step with this will be discussions and suggestions from members of the European ME Clinician Council, so that we can agree on what to do. This is my version of it, but I like to hear the others and their ideas as well. And the intention is then to launch the primer on the internet, so it's easily accessible. And in the beginning, we would have limited access. That's the proposal, to a few general practitioners that would collaborate with us and look at it and have suggestions for us. And then it's a hope that, I hope that many of our colleagues will participate in this process so we get a really good primer. And let's see. With that, I thank you for your attention.